Good morning, everyone. So I've been asked to speak about giving an overview of the general management of spinal trauma, in particular spinal column trauma. So significant spinal trauma is often involved in severe general trauma, and associated with severe spinal trauma can be catastrophic things such as spinal cord injury, neurogenic shock, etc. So the emergent management of those aspects of things are encompassed in the EMST protocols. The Asia Impairment Assessment Scale is a prognostic classification of spinal cord injury, and that can be used at the time of the injury as well to help determine whether spinal cord injuries or neurological injury is incomplete or complete, and then that dictates what are the best treatment options at the time. So spinal cord injuries mainly due to motor vehicle accidents and falls, although it can also occur in the setting of the absence of a fracture when there's instability of the ligaments. As with any spine management, spinal column trauma is controversial, everything ranging from classification, indications for intervention, timing, and surgical approaches. All can be managed in a myriad of ways, all relatively, quite well in their opinion, in the specific surgeon's opinion, but it is still very controversial. So first of all, we'll look at cervical fractures, most of which are due to falls and motor vehicle accidents. In trauma itself, there is quite a, the region of site of the fractures can vary. Usually it tends to be more in the lumbar spine, but this is an example of one of the papers where there's a variability in position of the fracture. When there is spinal cord injury, however, almost certainly that the cervical spine is involved. So with respect to images that are used to assess, plain X-ray has been pretty much superseded by CTs and MRIs, but they're good sort of tools for screening in patients who perhaps have had some trauma but are not too unwell and perhaps are in remote areas. They're also good for surveillance post-operatively and or for later stages as well. So again, just a knowledge of the pre-vertebral swelling that is evident. They're good at looking at alignment, possible subluxation, dynamic views if it's appropriate. If we think if there is a suspicion of instability, but that any movement is not going to compromise any neurological activity in obtaining the flexion extension films, and that's done. And of course, sometimes fractures can be seen, and looking for distraction or asymmetry in open mouth views. So the CT scan is really good at visualising alignment and fractures, bony anatomy, looking at the craniocervical junction, and also good at looking at soft tissues, but not as good as an MRI. So the MRIs is good at looking at the potential neural damage and ligamentous damage, and also looking at intraspinal hematomas and other collections. So first of all, we'll look at the craniocervical region. Injuries can range from something relatively benign, such as a mild strain of the ligaments or dislocation, or something as severe as a dissociation. The real dissociations are quite rare. It has a very high mortality. Commoner in children who have the lax ligaments and muscle stability of that area, and often patients are pedestrians struck by cars. So the presentation can be anything ranging from having a relatively normal neurological exam with some neck pain only to sudden death and or brainstem injury amongst that spectrum. So if patients arrive with a very poor neurological state in pedestrian versus car with a high force involved, then there's a high suspicion of this. In the emergency situation, patients who have the dislocation are usually hemodynamically and respiratory unstable. So using the EMST protocols, the management is according to that to also immobilise the time. But if they survive, then the definitive management is posterior occipital cervical fusion, ranging from short constructs to much longer constructs. Occipital fractures are not uncommon. There generally is 3 types. The first 2 are usually stable and can be managed conservatively. The first one is more of an impaction involving the condyle itself. The second one extends into the basilar skull region, but ligaments are intact. And the third is where there's disruption of ligaments and hence the need for either halo stabilisation or actual fusion, particularly if there's subluxation. So C2 fractures are also not uncommon. Usually young adults in motor vehicle accidents or the elderly having a low impact fall, they're usually intact. There are 3 types that in the commonest classification, and they're usually associated with different mechanisms of injury. So a hyperextension injury usually gives a posterior arch fracture. There might be an accompanying odontoid fracture. A lateral compression usually results in an anterior fracture. Comminuted lateral mass can lead from lateral distraction injuries, and axial compression injuries can lead to Jefferson burst fractures. So in these situations, when there's a fracture, always check for the vertebral artery, given the proximity of it to the bone. The ones that are stable, such as the isolated anterior posterior arches or a non-displaced Jefferson fracture, can be managed conservatively. If they are unstable, depending on the amount of displacement, they can be managed in halo frames. But if there's a significant displacement, then a posterior fusion is also indicated. Odontoid fractures are, again, commonest of the C2 fractures, and again, common in cervical spine fractures. And again, the etiology is usually of a young person in a motor vehicle accident or an elderly with a low energy fall. The Anderson-D'Alonzo classification is the commonest used. There are 3 types. The first and third are usually seen as stable, whilst the second is seen as unstable due to the poor vascular supply and increase in non-union of the type 2. And management can vary for the type 2 from anything from a collar to fusion, depending on the thought of stability. So with the odontoid fractures, when we think that they are unstable, surgical intervention is required, and the type of intervention can either be anterior or posterior. Anterior screw fixation is more favoured in patients who have displaced fractures that are not stable. If there's an anterior-inferior oblique fracture, so there's more of a tendency of instability. The patient has multiple trauma, is unable to tolerate a vest, such as a little old lady, or there's displacement despite the halo vest. And posterior stabilisation with either wiring or screws is more for patients who have had perhaps an unrecognised fracture for for quite a while, a number of months, and therefore has probably unlikely that they're ever going to fuse, even with an anterior screw. So relative contraindications for the anterior screws, if they've got a barrel chest, so it can make it difficult to get the right angle to get the screw in. If there's a transverse anterior ligament injury, so there's a risk of subluxation, and also if the injury is subacute, as we mentioned. Hangman's fracture in the C2 is rare and actually a hanging. It's a bilateral fracture traversing the pars interarticularis of C2 with the associated subluxation usually of C2 on C3. People who hang themselves usually die of brainstem injury. It's a hyperextension axial compression mechanism. It's after the Dens fracture, it's the next common fracture of the axis. Usual mechanism is a young person in a motor vehicle accident. Usually they're neurologically intact because actually the fracture itself affords opening up the canal if there is a minor displacement. So there are 3 types again with the commonest classification. The first type is where there's minimal displacement. It's managed in the collar. A little bit more risk of further displacement is for type 2 and type 2 fractures. And so it's recommended they be placed in a halo, and formal fixation for fractures where there's also a dislocation. With the subaxial spine, the classification is mechanistic rather than prognostic. There are many classifications, a lot to do with the mechanism again, with, I guess, the determination of whether a fracture is stable or unstable. There's a nice new classification that was brought out by Vaccaro in 2007 called the SLIC classification. And there's a similar one in the thoracic spine, which I find is very easy and simple to use. I just have this photo in my phone that I can look up. So it basically looks at injury morphology, the posterior ligament integrity, and the neurological status. And it then gives us a score which outlines whether it's non-surgical or surgical management is recommended to give the best outcome. Just a couple of things: when there's patients with ankylosing spondylitis or disseminated idiopathic skeletal hyperostosis or DISH, there's a significant risk of devastating injury. So patients who present with this often present relatively well neurologically, but once they're manipulated, they can lead to catastrophic outcomes with surgery. Central cord syndrome, again, is controversial with respect to timing of surgery. So with the thoracolumbar classification, again, multiple classifications, either morphologic or mechanistic. There's the 2-column, the 3-column, etc. And again, based on either morphology or mechanism of injury. And here we are with Vaccaro again. He gave us a really good TLIC score, which is used in thoracic spine. I think it's a really helpful thing to use, particularly when there's a time critical aspect of patients who are coming in with trauma. I guess there's a need, if they've got incomplete or complete spinal cord injury, as to where patients move on to, if they need to go to a tertiary centre for rehab from a spinal cord injury point of view, or whether they can be managed, or they need to be managed acutely in your hospital if you don't have a spinal cord centre. So the first thing they look at is injury morphology. There's compression with different, as part of a different prefix, compression axial fractures, lateral flexion or burst compression fractures, distraction, translation, rotation. The next is the posterior ligament complex. They look at whether it's disrupted in tension or not disrupted in tension, because the posterior ligaments allow indicate the integrity of the tension band, which allows, which gives an enormous amount to stability in the spine and sagittal balance, which Dr. Awad will probably talk about. Then the final thing is neurological status, so whether patients are intact or not, and also whether there is complete or incomplete injury that will dictate whether, I guess, this timing of surgery as well. So non-operative versus operative management in the spine with the brace or cast, they're usually the compression fractures, the stable burst fractures, pure flexion extension injuries, and cases where there's a small risk of neurological deficit without surgery. For those patients who are having surgery for spinal cord injury, for those that are incomplete, it potentially potentiates improvement neurologically and rehabilitation, whereas those with a complete spinal cord injury, it allows them to mobilise. Dr. Awad will talk more about anterior versus posterior approaches. Generally, the anterior approaches, there's more predictable decompressive aspect to the surgery. It can save the number of levels that need to be involved in the surgery and better restoring sagittal balance, which is the natural alignment of the spine. The posterior approaches have usually less morbidity, but do usually require more levels because often there is failure with the short constructs, and usually there's less blood loss. So using the TLEX score, this is an example how it can be applied. We've got a 77-year-old lady who's severe osteoporosis, fall from standing height with no deficits. So if we look at the morphology, we think it's a flexion compression fracture or a burst fracture, so that gets a score of 2. We know that the the posterior ligament complex is intact, so it's 0, and she's neurologically intact. So the point is 0, total points is 2, which is non-surgical and non-operative. In some centres, they might even consider a vertebroplasty if they've got a lot of pain, but that's controversial. This is another example, 6-year-old male, motor vehicle accident, low back pain only. So with the morphology, again, flexion compression burst fracture. In this situation, we suspect that his posterior ligamentous complex is involved, so he gets scores of 2. He gets the points of 4, where there's a bit of a grey area, can be managed either non-operatively or with surgery, depending on their bias. And flexion distraction injury chance, so that occurs when there's a seatbelt injury. There's a seatbelt injury associated with these chance fractures usually. There's a 55-year-old male driver who had lower back pain only. He had this fracture which ran through the body and into the facet joints. It's a flexion distraction injury, which is called a 4. He's got ligamentous injury, which is 3. So he's a definite surgical candidate, even though just on spec, it looks like a fairly benign fracture. So could ask the audience to see how they go with using this score. It's quite easy. Second row, gentleman in the red T-shirt. Has he been listening? Do you want to have a go using this score? So this is a 50-year-old male, fell from a ladder, lower back pain, no deficits. So this fracture goes to the back, but this is intact.
In a score in 2.
So burst fracture? What's the PLC? 0?
Yes.
Neurological status 0, 2. So
yeah.
Excellent. Score 2, non-surgical. Okay. Maybe hand it back to the next person. Oh, behind maybe.
Yes.
Okay, so we've got a 28-year-old male skiing accident, presents with lower back pain, bilateral leg weakness, paresthesia, diminished PR. So this fracture involves the body.
The morphology 2 point.
Pardon? The morphology?
Yeah.
Which one do you think?
2.
2, yeah. And the posterior ligament, it's a bit deceptive, but
2.
2, correct. I would agree. And neurology, 2,
2 also.
2 or 3? 3, probably 3.
3.
Yeah, because he's got some leg weakness, diminished PR. Yeah.
Yeah, 7 point.
Yeah. So I got this as chance fracture. I got as a 7. So yeah, suspected, incomplete. As you can see, the incomplete has a bigger score than complete because there's more of a need to decompress in a timely manner to try and regain function. That's a bit aggressive. I think you could get away with just doing a decompression and screws to above and below. There's many ways to manage. And last one. Who's got the... Okay, so we've got an 18-year-old female rollover, lower back pain and tenderness, and she's myelopathic. So she's got a fracture here. You can see it's not quite in alignment coronally. What would you give morphology?
Very point in morphology. I guess is the distraction 4 point.
Yeah.
And with
Could be.
PLC,
What about translation?
translation? Yeah,
Maybe translation.
Translations,
Yeah.
PR 3 point. Yes.
Distraction, you would see more of a, I think you'd probably see more of a space between the vertebrae.
3 point.
Yeah, 3 points. And
Yeah.
the posterior,
Integrity of PLC and get yes
yeah, you can see how it's open here.
3 point.
Yeah, so that's 3 points too. So already we're moving to
Neurology, I guess.
myelopathic.
Neuropathic called Akina with 3 point.
3 points, yeah, sure. So again, this is definite
Is it 9?
surgery. Yeah. So sometimes, I mean, I think it's good to use when, you know, it's in the middle of the night. Perhaps you're more of a junior surgeon. It's helpful because you don't want to ring up your senior surgeon mentor as to how you should manage. Should it be first case in the morning? Should you do it in the middle of the night? Or can it wait till the next elective list? So I just think it's a helpful thing to use. But in general, when I think about spinal trauma, I think what structures are damaged. So is it ligaments? Is it disc? Is it bone? Is it neural stuff? And then if the neural structures are damaged, do I need to do something immediately? Because there's, there's impending damage. Or is there impending damage that could occur to the nerves, and therefore do I need to do something quickly as well? So the ligaments, if the ligaments are injured and the spine looks stable, then we can manage conservatively. If the ligaments are injured and it looks like there's instability, depending on how bad it is, you could try and manage conservatively, but also at the same time, you could intervene surgically if you
1 minute.
are perhaps more aggressive. The ligaments are usually damaged if there's a fracture. If it's stable, can manage conservatively. Ligaments are damaged, cord or nerve injury, but it looks stable. Again, I think you can, depending on if there's compression there, you can intervene surgically or manage conservatively. If there's a fracture, we assume the ligaments are damaged and it's unstable. It's pretty certain that surgery would be involved, but if they have a complete neurological injury, then conservative management can be also an option that we mentioned here. If they're incomplete, I think it's more something that you need to go to surgery. Thank you.